Okay, so let's review anatomy and physiology. So we have the master gland, which is the pituitary gland, which controls all other endocrine glands in the body. So for today, we're talking about the thyroid gland. So this is an endocrine disorder similar to diabetes insipidus and SIADH. So there are two possible problems here. You either have too much of the hormone or not enough of the hormone. In the case of the thyroid gland, there are three hormones produced here. They are T3 and T4. So they are responsible for controlling the metabolic activity of the body. Now, a few facts here will help you remember as we go with testing and applying what we know about the disorders. So take note that these are synthesized and stored in the thyroid gland. Okay, so again, are they stored in the thyroid gland? Yes or no?
Yes.
Yes, okay. So there are at any given time, we have circulating T4 and T3, okay, at any given time. So we have a steady level of T3, T4 hormones already in the bloodstream. They are also stored in the thyroid gland, meaning it doesn't have to be made constantly and then meaning unlike let's say who drinks bubble tea here? No, boba tea, right? So when they make the boba tea, do they put them on the containers already and then you pick them up and then you buy one and then it's already made, or do they make it fresh for you?
Fresh sometimes. I think they do make the ones
They make
there,
fresh.
but fresh.
They make it fresh. So it
Uh-huh.
doesn't work like that in the thyroid gland. So they already have the boba teas, T3 and T4 boba teas in the cups. All right. It's already stored. And then when you come, you want some, they'll give it to you. Okay. So that's how it works in the thyroid gland. So they have T3, T4 stored, and they also have some already circulating in the bloodstream. Do you understand so far? You follow?
Yes.
Okay, so that's how it is. Now, besides T3, T4, there is a third hormone secreted by the thyroid gland, which is calcitonin. T3, T4 again are responsible for the metabolic rate of all the body cells, meaning the levels of T3, T4 determine the metabolic rate of our body. So if we have too much T4 and T3 levels, we will have what's called hyperthyroidism. If the problem is the opposite, we don't have enough T3, T4 circulating in the bloodstream, then we call that condition hypothyroidism. Now, calcitonin, which is produced by the thyroid gland, has nothing to do with the metabolic activity. Calcitonin is produced in response to abnormal calcium levels. There's only one purpose of calcitonin, and that is to lower serum calcium levels. How does it lower serum calcium levels? Well, it will tell the kidneys to eliminate calcium, and also it will promote the transfer of calcium from the blood into the bloodstream. Okay, so that's how it lowers serum calcium or calcium levels in the blood. As we know, our body functions by negative feedback. So therefore, if the T3, T4 levels are low, and this is controlled by the pituitary gland, the pituitary gland produces thyroid stimulating hormone, also called thyrotropin. Now, because of the term, just by the name itself, thyroid stimulating hormone, what will this hormone do? This comes from the pituitary gland. Thank you for reading, Cornet. You are muted, Juanita. I can't hear you. What's the that's okay. So what about Sasha? Read that statement, please.
TSH controls the rate of thyroid hormone release through a negative feedback mechanisms.
Okay. So through negative feedback mechanism, what does it control again? The rate of thyroid hormone release. So we discussed earlier that T3, T4 are stored in the thyroid glands, correct? So therefore, TSH is released by the pituitary gland depending on the level of T3 and T4. For example, if the T3, T4 levels are low, what will happen to the TSH level?
Would it be high?
Very good. So negative feedback. If T3, T4 levels are low, that is now the trigger, that is the stimulus for the pituitary gland to increase the production of TSH. So the higher the TSH, that will cause the thyroid gland to release more T3, T4. Now let's go the other way around. What if the T3 and T4 levels are already high? What will happen to the TSH level?
It would be low.
It'll be low because it will, again, influence the rate of thyroid hormone release. It will, therefore, TSH, which is produced by the pituitary gland, controls the rate at which the thyroid gland releases the thyroid hormone release. It doesn't make the thyroid gland make more. Okay, it just causes them to release it. Because remember, we already made it and it's already stored in the thyroid gland. Remember the boba tea? Okay, so they already made it. It's already in the thyroid gland. All they need to do is to release it. And the rate of hormone release, T3, T4, is controlled by the TSH, which is produced by the the pituitary gland. Do you follow that so far?
Yes.
Any question? All right, let's go to, as I mentioned already, calcitonin is the other hormone, and this is one function, which is to decrease serum calcium levels. As you can read here, the hormone is secreted in response to high serum calcium levels. So if the patient has hypercalcemia, calcitonin will be released by the thyroid gland to drop serum calcium levels. And here again, how does it do it? It increases the transfer of calcium from the blood into the bones and into the teeth. Any question? Very good. Now let's go to the problems now. Let's start with hypo. Hypothyroidism is a condition wherein the thyroid hormones are low. Okay, the patient doesn't have enough T3 and T4 levels. There are two forms though. There's a primary and a secondary form of hypothyroidism. Causes are different. In both conditions though, T3 and T4 levels are low. Now, the primary form, which is the most common, is called Hashimoto disease. This is an autoimmune form. What do we understand when we say autoimmune? What's wrong with the condition when it says autoimmune?
The body is fighting itself. I
Okay.
guess so. Fighting itself.
Correct. So the immune system attacks the thyroid gland, meaning the patient's body has antibodies, produce antibodies to destroy the thyroid gland. Okay, so that's the problem with Hashimoto disease. So this is an autoimmune form. This is the primary form of hypothyroidism. Okay, this is also the most common. Majority of people who have hypothyroidism have the Hashimoto type. There is a secondary form wherein the problem is with the pituitary gland. Okay, it's not a thyroid gland problem. It's a problem with the pituitary gland. So the pituitary gland in this case is defective. Usually there's a tumor there that causes TSH levels to be low. So of course, if TSH levels are low, what will happen to T3, T4 release?
Low.
It will decrease as well. Okay, so that's the secondary form. So in primary, which is Hashimoto disease, where is the problem? Is it with the thyroid or the pituitary?
Is it thyroid?
The thyroid is the problem in Hashimoto disease. So it's an autoimmune problem. The patient's body produces antibodies to destroy the thyroid gland. So therefore, what will be the TSH level in a patient with Hashimoto disease?
It's gonna be high?
It's going to be high. Do you follow?
Yes.
Okay. There's also a third type called what do we call again a condition which results from the treatment of another condition? Iatrogenic. 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 When we say iatrogenic, it results from either a procedure, usually a surgical or a diagnostic procedure that results in another condition. For instance, treatment for hyperthyroidism, particularly primary hyperthyroidism, involves surgical removal of the thyroid gland. So if a patient had hyperthyroidism in the first place, primary, which is the opposite problem of hypo, when we treat it, usually with either surgery or it could also be radioactive therapy, meaning we gave the patient radioactive iodine to destroy the thyroid gland, that is called iatrogenic hypothyroidism, meaning it resulted from treatment for hyperthyroidism. Okay, so again, here, either treatment with radiation, with medications, or surgical removal of the thyroid glands. Any questions so far?
No.
Okay. So there are three forms. The two most common are primary and secondary, and then there's a iatrogenic type, which is an unfortunate consequence of treating hyperthyroidism. As I already mentioned, so majority, 95% of patients who have hypothyroidism have Hashimoto disease, which is the autoimmune. Now, you'll see there's always a, because is this acute or chronic? Is this acute or chronic condition? Hypothyroidism.
Acute. Acute.
This is chronic. Okay, so this is forever. Patient with hypothyroidism, this is for life. So primary, secondary, or iatrogenic, that is a chronic condition. Because it's chronic, can they have acute exacerbations?
Yes.
Yes, so just like heart failure, just like COPD, which are both chronic. These patients as well who have chronic state of hypothyroidism will have acute exacerbations. So this is a severe form of hypothyroidism, meaning all the manifestations we will see shortly, are increased, which can be life-threatening. Patient can die from either respiratory failure, shock, or severe hypoglycemia. Now we'll get to that shortly. That condition is called myxedema. Okay, so this is a severe form of hypothyroidism. We'll get to that later because it has a special section because it's life-threatening. We'll discuss manifestations and then management for that separately. Here are the causes of hypothyroidism again. I already mentioned the most common, Hashimoto. And the others are treatment here, iatrogenic as well, iatrogenic, or the secondary form, which is pituitary problem. Manifestations. So imagine a person who has very low metabolic rate. The metabolic activity is very, very slow. So what will happen? Every cell in the body, from the brain to the heart, the kidneys, the GI tract, the skin, everything is very slow. What will the patient look like? Do they have enough energy?
They will be fatigued, like and tired.
Like weakness.
All right, so we have fatigue, lethargy. They will gain lots of weight even if they eat very little. Cold intolerance, dry skin. That's not it. We have, here's the list. Figure 45-5. So everything is slow. So from the skin to the hair, all over the body. Okay, all body systems will have slow metabolic activity. So here, lethargy, impaired memory. There will also be thickening of the tongue. So the tongue will kind of protrude here because it enlarges, so therefore it doesn't fit inside the mouth anymore. There is a puffy face, cold intolerance, meaning they get cold easily. They will have bradycardia or slow heart rate. The heart will enlarge because of the resulting bradycardia. They will have very slow motility. So what will happen to their bowel movements?
Constipation.
And there's constipation. And as already mentioned, because the metabolic rate, their cells are burning very little fuel because their cells are working very slow. So they require less energy. So even if they eat less, they continue to gain weight. There will be edema as a result. There's also muscle weakness because everything is slow. Even the circulation is slow here. Okay, that's why that's the cause of the edema in these patients. Plus, of course, the slowed activity of the heart as well. So circulation is very slow. Any question? Right. So these are some of the complications related to hypothyroidism. So pleural effusion is the accumulation of fluid in the pleural cavity, meaning the sac around the lung, or that sac around the heart as well will also have fluids. And as already mentioned, everything is slow. So if they're weak, you have muscle weakness. There's also weakness in the diaphragm. So the breathing muscle is also weak here. So there will be, there could be respiratory failure in these patients. So here's the myxedema part. Myxedema coma is a rare life-threatening condition. So it is stated as it's described as an acute episode of hypothyroidism. So it's a decompensated state of hypothyroidism. The patient here is hypothermic and unconscious already. So because they're unconscious and they're hypothermic, how will we administer the medications here?
IV.
IV.
Everything will be IV.
Well,
So the the day-to-day treatment for hypothyroidism is oral hormones. So we give them because they're low on T3, T4. So we give them the thyroid hormones in a pill, usually given early in the morning before breakfast. So this falls on the night shift people. So night shift will be giving these to the patients before breakfast. We do it that way because the natural release of thyroid hormones by the body normally is in the morning. So that's why we try to copy how the body normally releases the hormone. So we give it early in the morning as well. So what will cause people with hypothyroidism to develop myxedema? So here are the possible causes. So one cause could be the patient had no idea that they have hypothyroidism, meaning this is the first time they found out. Okay, so just similar to DKA. So one of the causes of DKA is the patient didn't know they had type 1 diabetes. So same thing here, patient had no idea. The condition was undiagnosed and then they found out the hard way. Okay, they went into myxedema coma. Another condition that can lead to myxedema is if the patient uses a lot of these drugs. They take too much sedatives, too much opioids, and they have hypothyroidism. Because what happens to their drug metabolic rate? Drug metabolism. What happens to it? Is it normal?
Slows down.
It also slows down. So as a result, when they're taking these drugs, what happens to the levels of these drugs in the bloodstream?
increase.
It increases and then leads to or precipitates myxedema. We'll get to the manifestations shortly. So here's another cause. The patient is diagnosed and they're supposed to be taking the thyroid hormones, but then they're not taking it. Or it may not be the patient. Okay, it could be the nurse not giving the thyroid hormones because given what you know so far about these patients' manifestations, like the lethargy, the fatigue, and what time are we giving these drugs to them?
Early morning.
Early in the morning. So if you have this condition, you have all these manifestations, and then here comes the nurse waking them up at 6 a.m. What do you think they will say?
No.
No, leave me alone. Right? So they like to sleep in if they have this condition because they have fatigue, they have lethargy. They're not going to take the pill. So therefore, what will the nurse who, let's say, doesn't understand the condition very well, and then the nurse just says, oh, I don't care. You don't care? Why should I care? Right? And then the nurse will just throw away the thyroid hormone or document it as not given. What will happen to this patient? Their body is not producing T3, T4. So their only source of this hormone is the pill. And then here comes the patient not cooperating very well, which is expected. And then the nurse who is not caring enough to be resourceful on how to give this. So what will happen? Patient will go into what? So can nurses be responsible for this condition? Can nurses be responsible for this condition?
Yes. Yes.
Yes, we can be. So in myxedema coma, so you'll see that they're going into this condition. These are the early signs. So they have depression, lethargy, diminished mental status, and somnolence. Okay, and then if the patient continues to not receive the thyroid hormones, it will progress to stupor. Stupor meaning they're no longer responsive. Okay, they're just they're almost catatonic. They're just like this, so just staring blankly, not responsive. I mean, they're awake, but not responsive at all, and they'll go into respiratory failure. Lungs will collapse. They go into respiratory acidosis, and then this is now what's going to kill the patient. So that because they'll go into hyponatremia, hypoglycemia, hypoventilation, hypotension, bradycardia, and hypothermia. Can these kill the patient?
Yes.
Yes, definitely, 100%. Patient will will die because of this condition. So all this could have been avoided, correct? By simply giving the thyroid hormones. But here we are now. So let's say the patient is already in myxedema. And as we said, based on the description, the patient already lethargic, already in stupor, for instance, so no longer conscious. How do we give the thyroid hormone now?
IV.
Okay, so it does come in parenteral form, so we can give it IV. Granting you have an IV site, you give the thyroid hormone intravenously. Okay, so the doctor has to change the order from PO to now IV, and then we will support the patient. So we'll get to the overall the complete management of myxedema later in this chapter. So for hypothyroidism, this is the treatment. Levothyroxine, just one pill. So it can range usually 75, 150, but there are smaller doses because the drug can have different effects on the patient, and we don't know how they react to the synthetic form of the hormone. So we always, this is the, can someone read this, please?
Treatment is generally started at a lower dose and trickled slowly until desired levels of serum TSH
Concentration.
Okay, so what do we mean by titrating again? Titrate is to?
increase
What's the better word? Because it doesn't just go one direction.
or decrease.
Okay, so therefore, what's the correct word?
Adjust.
Adjust. Okay, so the
Adjust.
dose is adjusted depending on the patient's TSH. All right. So we always start low. The lowest dose I've seen is 18 micrograms, and the highest I've seen is about 250 micrograms. So we can't put the patient on the high dose right away. So we always start low. So maybe we'll start at 18 or 22 micrograms. And then every few weeks, we will look at the patient's TSH levels. The doctor will draw blood samples for TSH and T3, T4 levels until we reach a normal level. Okay, this is done over several weeks at a time. We don't do the high dose right away because this is the purpose of doing that. We want to prevent cardiac dysfunction. We don't want the patient to go into cardiac arrest because, again, we don't know how exactly the patient's body will react to synthetic levothyroxine. Okay, because this is different from our own body's hormone, which is produced by our own body. This one is from a laboratory, obviously. So we until we know how it affects the patient, the dose has to start low, and then we increase slowly every few weeks. Any question?
No.
All right. So here's a QSIN alert. Please read that. Yeah, again, very important. The most important responsibility of the nurse when giving this hormone is to monitor cardiac function. We cannot start high doses. It has to be titrated slowly because we want to prevent any heart attacks. All right. And here's really something related to that. So if the patient does have any cardiac symptoms after administration of the drug, then we should stop it right away and then draw blood levels. And then the doctor will have to change the dose. Obviously, if they show these manifestations, are we giving enough, too much, or not enough of the hormone?
Too much.
Too much. Very good. So again, we don't know how much the patient's dose will be. So that's why we always start low. And then until we get to the appropriate dose, patient will have to be patient. Because of this pattern of treatment, will the patient's manifestations improve right away?
No.
No, right away.
No. So that's something you have to explain to the patient, that be patient, okay, and then explain to them why the treatment is this way. Okay, so we're trying to avoid the cardiac complications that could result because of the therapy. All right. And again, a warning. Remember the causes of mixed edema earlier? It's caused by what? Undiagnosed or non-compliance with the treatment, or it could be the nurses not giving them, or the patients are taking what medications? The opioid medications, the sleeping pills, okay, the CNS depressant drugs. You must be very careful when you're giving it to hypothyroid patients, because what happens again to their drug metabolism and excretion?
Everything decreases.
It's very slow. So drug excretion, drug metabolism is slow. So what happens to drug levels of these medications?
It increases in the system.
Increases. All right. Nursing management, so it involves safety. Okay? Make sure the patient is conscious before you're giving them anything by mouth. Support oxygen. If you need to give oxygen, then give it. Keep them warm because they have cold intolerance. Just be careful you don't burn them because sensation is decreased as well. And make sure you have sheets in between the heating pads, so don't apply them directly to the patient's skin. Now for the mixed edema, so here's the management and teaching for the patient. So keep in mind that this is caused by the, what are those three causes we mentioned again that lead to mixed edema?
Deficient knowledge.
Medication,
Yeah, they were undiagnosed. What else?
non-compliance to medication,
Compliance, or it could be not the patient but the nurses, okay, not giving it. And then the third, it's precipitated by what? Meaning what conditions will cause them to have a higher metabolic need? Can it happen when they're sick?
Yes.
Yeah, because when they're sick or when they're having trauma, either physical or emotional illness, what happens to their metabolic requirements?
It increases.
It increases. And then their current dose of the medication, is it enough to supply that increased metabolic demand?
No, it's not. You gotta change it.
No.
Okay, very good. So can it possibly lead to mixed edema?
Yes.
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 All right. So you teach the patients all these possible causes and then the manifestations especially. Any questions?
No.
Okay, very good. Let's take a break.